This presentation was a part of a kind of a workshop that dealt with digital well-being. Generally, the idea was that over the past, let's say, 15 or 20 years, our use of technology and online venues such as social media and so on became quite prevalent, and this could have direct effect on our well-being as adults and young people as well. There's quite a lot of research trying to look at different relationship between the amount of use and let's say psychological traits, and also psychological outcome, or what may be related. So the question is, what leads to what? Is excessive use based on one's traits? Is it that using a lot of the social media influences well-being and let's say depression, anxiety, and so on? Is it a sort of a self-therapy? There's a lot of research in that area, including fMRI related research, not much of that, but a little bit. And just generally, let me tell you that after one day of this workshop, I just removed my own Facebook and Instagram from my cell phone, being aware that maybe it's taking a bit too much of my attention and my time. I'm not saying it's the first time that I've done that, but it's one of those times that I realized that maybe it's taking too much of my time, and it's really designed to do that. And I consider myself to be quite a, let's say, reasonable person who has some level of free will, but potentially having our decisions engineered for us by very smart, let's say, applications and so on, might lead us to be more influenced than we are aware of. And so I'll present my presentation. It's based on a paper that we wrote on the democratization of mental health. So we focus on generative AI, but I will refer not only to that and connect it a bit to what we've done over the past few months after the October 7th attack on Israel, which led us to maybe move from theoretical conceptual work to actually building a tool. So in a way, while I have a lot of worries about the democratization of mental health and especially mental health treatment, at the same time, the fact that something could be scalable might also mean a maybe not a quick fix, but a partial solution at times of need. So the term democratization may be defined as the following. So the process of making knowledge more accessible. So the democratization of knowledge, and if it's mental health related knowledge, then we can look for mental health related information online, but it's not only websites. You also have wiki platforms. And just to think about it, we have wiki medicine. We have medical students adding information and updating information online. And, we have the 5 minutes information, we have up-to-date, we know all of that. So basically, this is not new, that there is more accessibility of mental health related knowledge, not only to professionals, but to the general population as well, with varying degrees of accessibility and levels of, let's say, abilities needed to actually understand and grasp it. Now, when we talk about accessibility of knowledge, is it inclusive? Is it transparent? Is a wide number of people able to not just read it, but understand to what level? Is it accurate? Is it tailored to their own needs? And this definition is from 2005. So let's assume that today, if we're talking about generative AI with its limitations, but also abilities, that might mean that we could have tailored, personalized access to mental health related information, and that could be something useful, but also something potentially dangerous. So talking about democratization, we can use the current abilities of generative AI, such as ChatGPT and other of these general purpose engines for patient education. several of my students are actually looking at that. So I'm teaching in the nursing department, and a part of what nurses do, for instance, in oncology, is patient education. So they're checking first, how would nurses view the use of generative AI as a tool to facilitate their own preparation for patient education, or potentially asking questions when they're asked questions by the patient and they're not sure of it, to what extent they feel it's accurate, it's helpful, it's constructing the sentences and explanations in a well manner, in an empathetic wording, and so on. So patient education, psychoeducation, potentially using these models could be facilitating shared decision making, or could kind of be an alternative for the medical doctor or other professionals' efficacy, or their source being a source of information. So as I'm going to show soon, I think if we use it in the right way, or if we construct these models in the right direction, they could actually facilitate shared decision making, potentially by making information more easy to understand, by allowing follow-up on maybe less accessible explanations given by professionals in a way that would be easily understood and learned, that you can have a Q&A and so on with these tools. We can both also use generative AI and technological tools for self-care. And actually, at some cases, it seems that maybe they are defined as well-being tools and self-care tools in order to avoid saying that this is therapy. So in a way, is it self-care, or is it just a way to avoid needing to have an FDA approval or so on? So this is a tricky one. But let's say I just want to do yoga or do some relaxation techniques. Do I really need to go to a therapist or to a course? Could I do some things by myself? In what way could it actually facilitate well-being? Let me just say that I just came back from a friend who lives in the Netherlands. He's a neuroscientist. He left his job at the university a year ago, and he set up a company to promote mental well-being by way of combining martial arts and his knowledge in neuroscience. There is, I think, a lot of room for thinking about other ways to help people. Not everything is merely psychotropics and other kinds of drugs or CBT. The question, I think, always is, how is it provided? What promises are given? What information do people get? To what extent they're given the full extent of possibilities, rather than saying, hey, leave everything behind. All you need is not love, but maybe our digital solutions that will provide you with access to the perfect life that you've always wished for. And I think the use of these digital technologies could, in some ways, actually enhance agency. It could enhance one's feeling that they're able to kind of steer the wheel. It really depends on how these technologies are used. And it could also provide a false sense of agency. And again, I started with telling you what happens with these TikTok and so on. I don't know if you've heard about that. I didn't until a few days ago. In China, they have the ability to regulate the way they think is the right way to regulate, including to limit the amount of scrolling that a teen could do when they're using their apps. So they could scroll as much as they want, but after 30 minutes or 1 hour, it's not going to show them any new information. In a way, it's a way to reduce one's dependency, which might be equated to any other kind of dependency. So this digital dependency, which there are some questionnaires and some people have actually defined it as a sort of diagnosis, is something to consider. We don't have much of regulation that actually allows this kind of interventions, but it's something to just think about. What do the Chinese know that they think we should limit this kind of excessive use, right? Now, there's a lot of talk about relational autonomy. So in a way, Autonomy is not necessarily my ability to write my own life story when I'm completely disconnected from the world and I live as an island and I have my free will and so on. So if I live in a more like a life that has other people in it, meaningful others, then autonomy could also be relational. So it's my decision that could relate to how people that I care about think and how they're helping me construct my own arguments and my thoughts and so on. And there are interesting questions about what kind of relationship are we going to have with the digital therapist or the digital aide or the digital co-pilot. And you might have heard of Replica, which is one of the chatbots that have been out there for some years. And I think over 7.5 million users reported a sense of care that they feel like they care for the chatbot. They care about it. They want to make sure it's okay. It's fine. It's doing well. Now, these are not psychotic people necessarily. It's just a sense that you get when you have these lengthy conversations with an agent, a digital agent that you know is not a person or is not a human being, but is being so kind to you. And this is something interesting that one may want to think about. Is it going to make some changes to how we view ourselves, how we view agents in the world, philosophically, I mean, and how we view relationships? And I sent you about a year ago a short paper we did that we called it the artificial third. And the person who kind of came up with this term and with a group of people, they just published their let's say lengthier article that they call the artificial third, taking from the psychoanalytical concept of the analytical third. What is this artificial third? So it was just published in the special issue that we're doing at the Journal of Medical and Internet Research, Mental Health. So the editor is John Torres. You might know him from Harvard Medical School and the hospital nearby you. And so we're trying to think about this new reality. It's something to think about conceptually and practically at the same time. We wrote about it about a year ago, talking about the question of what would be the therapeutic alliance. How would we see that if a part of the therapy is either given by or facilitated by this digital agent? It becomes something present in the therapeutic interaction, even if it's not a therapy driven by this agent. You know, it's my therapist told me, you talk about it with a smile, like you like this, whatever, right, agent. So that's interesting. How would one develop relation or feelings towards something that is clearly not a person? I think, need to think about it. And then, so one of the papers, which I just accepted yesterday, talks about empathy and the role of empathy in therapy, basically saying, well, you know, one thing the computer is not going to be able to really give us, and that's empathy. What do I mean by that? Well, it can give us the resemblance of empathy, but because it's, you know, it doesn't really need to give up on anything to be nice to us. It doesn't need to say, oh, I'm losing my patience, but I'm going to be nice to that person. No, it's a computer. It doesn't care. So in a way, you know, and it's not going to die. And it tells me, oh, it sounds horrible. It must be so hard to cope with those emotions. Yeah, but it doesn't know what emotions are, and it doesn't know what terrible is, and it's not afraid of dying. And so, you know, in a way, that might lead us to say that there isn't congruence there. You can't really believe it when it says that it feels something. So how could you look at this agent and say, well, it means what it says? And that is one of the reasons that one may say, using a digital agent, even a very smart generative AI textual agent, would not replace therapy. And, you know, maybe it's right. Maybe at the same time, not all therapy needs to be based on therapeutic alliance or congruence. Some methods are really practically giving us some tools to cope with our conditions. And I think for these kind of therapies, it really doesn't matter that much who's providing us with the information or with the technique, as long as we're following it. And so I'll share with you what we've done in this regard in a few minutes. So that's about the democratization of knowledge and mental health. It's exciting. There are a lot of opportunities there, but I think you could have heard also my worries that it might also be, maybe we're too excited about it, the possibilities. We're not considering, first of all, it's not there yet to some extent, but also when it is there, when it is there, where are we going to be, and are we going to like what we get? So if we're talking about, I don't think it's a new kind of data, but it becomes worse every time you look at it. So we're talking about a global mental health crisis, right? So many people are affected by various mental health conditions. It could be trauma or depression or anxiety or serious, severe mental illness, and so on. So obviously there aren't enough therapists, that there aren't enough resources in most countries in the world to provide people who actually seek mental health solutions and support, to provide them with the most relevant and useful maybe help that they would need. And if that is the case, then if we do have some solutions that are scalable, scalable doesn't mean it should be bad. It should be good and scalable. If it's bad, then we don't want to make it on a large scale, right? So a large scale mistake is a problem. But scalability is a real benefit. Now, I don't need to tell you how much an hour of therapy would cost. I mean, I don't know how much it is in Boston, but even in Tel Aviv, in Israeli terms, that's like maybe 500 shekels. So it's like, I guess, more like almost $120, $140. And that's in a country where things are cheaper, I think. So that's a lot of money, and not everybody can cover that. And I've seen how the insurance companies in the US are looking at the different codes and so on. It's not that easy in the US as well. And you got to find the right code, and you got to justify the 45 minutes, and you can't do one session of 45 minutes and another of 50. And I see how my friends are struggling to not cheat the system, but to understand how to write things down correctly in the system and so on. So it's not that affordable. It's not that accessible. And there are other reasons why it seems that people are seeking other solutions. People are more aware of mental health issues. We have the Mental Health Day and so on. We have mental health related campaigns. And there are a lot of technological advancement, and people assume that if they could potentially use any kind of preventive mental health care, things that relate to their ability to develop, how do we call it, the ability to sustain trauma, I forgot the word, then that's something desirable. So instead of waiting to be hit, potentially let's do something to build inner strength and so on. Now, there are many mental health apps. Most of them have never gone through any rigorous or non-rigorous testing or randomized controlled trial or any kind of trial. It's merely trial and error. And if there is an error, it's really not of anybody's problem in a way. It's like use it at your own risk or something like that. There are several bodies who are trying to kind of identify the good ones from the bad ones. So the Mental Health Alliance in Canada are doing a really good job at looking at different apps and recommending those that are potentially based on, let's say, rigorous guidelines, and their risks are limited, and they create a very interesting explanation of what they're recommending and why. So, Ed, is there something you want to ask, or you want to maybe ask it in a few minutes?
No, thank you, Oren. I can wait.
Okay. So there are a lot of mental health chatbots that are AI powered, and these are really actually cool. So some are really mostly for anxiety and depression. A lot are actually based on very well structured CBT protocol. So you could expect it's going to be a bit repetitive, but at the same time, it might use positive statements or other things. It's actually nice, and if you need CBT and you may have limited accessibility to a therapist, one may use it and may find it useful. I'm not saying there's a lot of long-term research showing its long-term effectiveness, but in many cases they seem harmless to some extent. Are they harmless? Are people going to settle with that even if they have suicidal thoughts? Well, hopefully not. So you can use different chatbots. You can talk to it. You can like physically, you can not just type, you can talk to it. It can talk back. Some actually have visual aspects in them as well. And it's providing with anonymity. So if there is some reason for you to be afraid of talking to a therapist and so on, you could potentially have an anonymous based therapy. Is it really anonymous? Are they really not using the data that you put in to train the model? These are good questions. If it, there's always this saying, if you're not paying for a product, then you are the product, right? So that's a big question, and these are things that some regulation is trying to maybe look at, but it's not very well regulated yet in many places in the world. So you have wearables and other things that can track mood. You might have heard of Behavidence, that they're tracking one's mood and changes in mood just based on their regular use of their cell phone. When October 7th came in Israel, Behavidence reported, well, not surprisingly, that they see a high rise in anxiety and depression and so on, basically only based on their simple data of cellular use. Some people say it's creating less stigma to use just their cell phone, and they're not going to a therapist, nobody sees them, and so on. But again, most of them are not evidence-based. So when we worked on this paper, we basically were trying to consider how would one try to define the desired democratization of mental health chats or mental health tools, digital mental health tools. And we looked at the following considerations. So is it accessible? And the question is, does it improve access to mental health services for diverse individuals? So, maybe different cultures, different financial abilities, different languages, different stratus of language, or, from different levels of education and so on. Is it providing self-care tools? Some people may just need some time to organize their thoughts or have some diary-related practices and so on. Is it providing people with informed decision-making? Is it providing them with information or just doing everything for them, so leaving them without their sense of agency or their sense of autonomy? Is it facilitating collaborative approach between patients and healthcare providers? So it's augmenting, like augmented intelligence rather than replacing therapists with digital support, potentially not allowing a person in the loop to make sure that all the person needs is this very simple intervention and so on. Or at least does it identify and tells the person, if this happens or that happens, please go to seek professional help and so on. To what extent is it inclusive? Can it adapt to diverse cultural, socioeconomic, and personal needs? And again, theoretically, a lot of AI models can do that, but it's not necessarily that they are doing that. So, this is something to check, and we can check it. And we've done a lot of actually of these tests to see how it deals with different types of content and different types of groups and so on. And maybe not most importantly, but very important would be transparency. So does it provide with clear information about what it does, what it cannot do? How is it using the information that it receives from you? And what is it basing the answers that it provides you? What is it basing it on? Okay, so these are like the major questions that we thought would be very relevant when we talk about let's say, an ethical approach to democratization of mental health using digital technology. And obviously, there are other issues such as privacy and security. These are always issues when we talk about any kind of digital technology, especially in health. Is it reinforcing societal biases and inequalities in mental health care? Because we know those exist. So can we kind of correct what the system is doing using digital technology? Or is it just kind of replicating whatever it is that we're already doing, right? Maybe it's a chance to do better. Does it develop, do people provide, like, become over dependent on that? Do they become addicted to it? Like, is it going to be a problem when you're going to ask them to pay $30 a month instead of $20 because they say, well, I'm addicted, I got it, like, you know, you cannot leave me. So are we going to kind of say that similar requirements that may be ethical requirements that you would have as a therapist should apply also when it's a digital kind of support system? And actually, that's a good question. How do you raise the monthly or, you know, the fee as a regular therapist, right? This is also an ethical question. So in a way, people who came to me for consultations asked me, am I okay with providing consultation to such companies as a therapist? Is it okay to help them build these tools? Or am I going to be liable if this computer is like going off the rails or doing something bad? Like, so these are questions that people are really dealing with today. Obviously, the question of misinformation. So some systems, well, they have the potential for providing misinformation or not based information, or just clearly strange information that makes statistical sense but makes no other sense in the world. And we've heard about the concept of hallucinations. I don't like this concept because it's not hallucinations. The machine is not thinking the way we do, so we shouldn't call it hallucinations. But obviously, the fact that it can produce something that sounds really convincing and is, you know, utter rubbish is a problem and should be, you know, kind of minimized and mitigated, and it could, and it is many times. Are there corporate related considerations that could influence what the system tells us? So for instance, if I'm training my system on proprietary information that I have, maybe I'm going to train it on the data that I already have rights in. Maybe it's only the drugs that I'm producing or selling. So potentially it's going to be biased towards whatever it is that I'm training it on, and not towards other information. It's not going to be available to it, for instance. So, right. So these are questions that one needs, and this is a non-intentional bias. What happens if I really want to kind of sell my own stuff or kind of promote my own ways of thinking? Am I going to be fair enough and tell the patient, when you use this system, we are only working with these kind of drugs or these kind of methods, and the other methods that are available, you should know what they are. We're not doing that. Are companies going to do that if we're not requiring it by law, if regulation doesn't say that they have to? I wouldn't count on that, right? Okay, and basically, is it overshadowing human expertise? So do I assume that the epistemic authority of this brilliant, genius, never-ending abilities of knowledge and analysis of the GPU or whatever the system is, am I thinking, well, it's much better than my human therapist, the fragile person that might die someday and can feel my pain? He's not as bright. Maybe I like it sometimes, but maybe I want something better sometimes. So these are questions that one needs to potentially just maybe consider. So I didn't even remember that I did it in a big text as well. So what I always say in this regard, and I'm nearing the end of this talk, is so we're only human after all. Maybe when we're running quickly to achieve this potentially life-changing technology, we should also remember these saying. Obviously, I found them based on using GPT and so on. Chi va piano va sano e va lontano. What comes slowly is healthy and can last long. Or in, I guess, Japanese, I don't remember exactly what it says, but you know, if you pour the water too quickly, it's all, nothing is going to be actually poured in. So it's not, you're not going to reach your goal. So just to sum up, so we looked a lot about using generative AI and so on. But then I talked to you about what happened in October 7th. And when we realized that there is such a need for, well, a lot of people sustained a very traumatic event. And it was quite clear that we're going to be needing to cope with that for a long time. And unfortunately, that is the case. And while not everybody who were exposed to these traumatic events developed PTSD, a lot of people are showing various signs that are at least PTSD related, which makes sense because basically for many, the event has still not ended. A lot of people are still in captivity. A lot of people are still in Army Reserve and fighting. A lot of people are still displaced from their homes. And all these are traumatic or potentially traumatic occurrences in their lives. And so as we understood that time is short and we need to develop something, maybe one day after the day of the attack, I was sitting with ChatGPT wondering if it could be helpful with building something that could be helpful in some way to people who have experienced something traumatic. And so that was my lab. And then I contacted the chief scientist of Microsoft Israel Research and Development, and he provided us with a large group of volunteers that could work with us. And together with my colleague, Professor Yael Lav from the Psychological Trauma Research Lab, and other colleagues from other universities, we worked on the personalized self-treatment system that is based on an EMDR based approach that was developed by Dr. Gary Queen. He's a psychiatrist, and he's been kind of working on this procedure for the past 30 years. It's a very simple, very structured, very rule-based, let's say, approach where one combines bilateral stimulation, which could be done either by touching the person or by asking the person to touch themselves or by moving your hands in a way that would lead them to follow them. And we adapted it to online use. Gary have done that in the Ukraine using Zoom, but we have thought that we wanted something that would be scalable. So can you use a chatbot that would just receive information about the level of distress that you are experiencing now, the major source of your distress? So is it feelings of guilt, feelings that you're still in the event, although it's already over, feelings of worries towards the future or towards others that are close to you, and so on. And once you choose the focus of your distress and the level of your distress, it offers you to basically go through a series of very short videos. We recorded 80 short videos with psychologists who are trained in EMDR. This is Yael, so this is my partner in crime. She's doing this, the butterfly hug. And all you're asked to is not to close your eyes, so not to withdraw into dissociation, which sometimes happen. And just do the bilateral stimulation while hearing specific positive affirmation that relate to your source of distress. Now, originally, this was supposed to be an AI tool, but then I realized that we don't need generative artificial intelligence. The protocol is already very clear. It works very well. Every word has been looked at and has been checked to be the most useful one over many years. Why change anything? Why leave anything to the possibility that things might actually go wrong, right? So just to sum up, let me tell you what were our considerations with building this tool, the ethical considerations. I am an ethicist, and as you see, it's the first time we've actually built a therapy tool because there's war and there's need. But ethics doesn't, you don't throw it out the window just because there's war. And although we wanted it to be, available as quickly as possible, we realized from the Ministry of Defense and from the Ministry of Health that they would prefer having something going through randomized clinical trials and be useful for a long period of time, and not just something that either works or not, because that is something, you have a lot of stuff that may work. They want something that has been proven to work. And so, cost, a therapist could maybe do 3 sessions an hour if you do a very short 5 to 10 ISP, immediate stabilization procedure meeting. This is endless. You could have 1,000 people using it at the same time. It's merely just, you just need a computer, maybe earphones, or even a cell phone, right? Efficacy. So it's already been proved efficient when you do it face-to-face and even using Zoom. And now we're starting the randomized control trial to evaluate that the fully self-administered digital intervention is also working and doing what it's supposed to do. One thing is to see that it provides with immediate improvement. That's easy to see in 10 minutes. A person starts at 8, and then reports that it's down to 2. But that is really very kind of anecdotal. Maybe it's just, maybe it's very short timed. 3 days later, if it's still better, then one would assume there is some consolidation of the memory or the change of, the connection they did between the event and, let's say, stressful reactions. And then we also do a 3-month mark to actually check for long-term efficacy. Is it safe? So in order to check that, we're going to use also Zoom with some of the participants to see how they're experiencing it, how they're behaving, because otherwise, if it's fully self-administered, we just don't know what they're doing, right? So that would be at least in this time. You can see the full trial in clinicaltrials.gov. So we registered it. Equality and accessibility. So, there are people in trauma centers coming right after the events, but not everybody's going there. Not everybody's interested in talking to anyone. And so in a way, the online access might be an additional way to receive it. And it actually started when we saw that we have many volunteers, a lot of my friends volunteers, but it's not enough. So we were seeking for an extra layer of support. Our initial thought is that we don't want to replace all the therapists in the world with computers. That's not our goal. It's just to create some extra layers of support for people who've sustained a traumatic event. And potentially, if all they need is this immediate stabilization procedure, they might not need something else if they do not develop later on more traumatic responses. So in a way, if this works, it may not become, the acute stress reaction might not become acute stress disorder. I know ASR has been left out of the DSM, but let me assume that it's not completely abolished from the world, just from the world of the psychiatric manual. But anyway, so this is something we're checking now. Obviously, there are questions of privacy. We don't collect private information. We don't need to know who it is that's using it, right? I mean, for the sake of the research, we are collecting information. People know that, but people feel safer. They don't need to share who they are, what they've experienced. And maybe the most important thing is, because this is a very minor EMDR treatment, it doesn't need you to go deeply into the memory in order to work. And that's the beauty of, generally, of EMDR, which maybe not everybody see as the most effective system, but there is quite a lot of work showing its efficacy. But the nice thing is that if you don't need to go into details of the event, then you're not, there's not a high risk that a person who's using it will become much worse just because they use this self technique of the hugging butterfly. So that's what I wanted to present. Most of the things I mentioned, we've already published or are waiting to be published. And I'd love to hear your thoughts and your comments.
Thank you very much, Oren. You get a lot of questions coming up, a little PIPATL. Thank you. All right, Oren, final salute.
Thank you.
Great stuff. Great stuff.
Thank
Thanks again.